Namaste Bitya, Hamisha Khush Raho Bitya. A very good morning to you all. Myself, JVM Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about COPD. COPD will be covered in 2 lectures, and today we are going to discuss about emphysema. COPD belongs to the chapter of respiratory diseases that we are discussing these days. So today, let's start with COPD. What is COPD? What is the definition? Etiopathogenesis, clinical features, investigations, and management of emphysema. All these things we are going to discuss today. What is COPD? COPD stands for chronic obstructive pulmonary disease. That is chronic obstructive pulmonary disease. So any disease of the lung that is causing chronic obstruction to the airflow. Chronic obstructive pulmonary disease, or COPD, it is a disease state that is characterized by airflow limitation that is not fully reversible. So there is limitation of the airflow and it is not actually fully reversible. So there is airflow limitation that is not fully reversible, and it includes emphysema, chronic bronchitis, and small airway diseases. So in COPD, 3 types of diseases will be covered. Number 1, emphysema that we are going to cover in this lecture, chronic bronchitis that we are going to discuss in the other lecture, next lecture, and small airway diseases that we are going to discuss somewhere else in this particular chapter. So what is emphysema? Emphysema is basically, it is anatomically defined condition that is characterized by the destruction and enlargement of the lung alveoli. So in emphysema, that there is destruction and enlargement of the lung alveoli. Chronic bronchitis, it is clinically defined as a condition in which there is chronic cough and phlegm. And small airway disease, it is a condition in which the small bronchioles are narrowed. So what is COPD, or the chronic obstructive pulmonary disease? It is a disease that is characterized by airflow limitation that is not fully reversible. It includes emphysema, which is a condition that is characterized by destruction and enlargement of the lung alveoli. There is also chronic bronchitis that is defined as a condition with chronic cough and phlegm. Chronic bronchitis is a clinically defined condition in which there is chronic cough and phlegm. There is small airway disease in which the condition in which the small bronchioles are narrowed. So we have emphysema, we have chronic bronchitis, and we have small airway disease. Now we come to the COPD. COPD is present only if there is chronic obstruction in the airflow. So if there is chronic airflow obstruction, then we will see COPD. It is the 3rd leading cause of death and affects greater than 10 million persons in the United States. Estimates suggest that COPD will rise from the 6th to the 3rd most common cause of death worldwide by 2020. Now, what is the difference between asthma and COPD? So we have to check what is the difference between asthma and COPD. There are 2 schools of thoughts. One is the Dutch school and the other is the British school. The Dutch gave the hypothesis that suggests that asthma, the chronic bronchitis, and emphysema. Asthma, chronic bronchitis, and emphysema are variations of the same basic disease. So according to the Dutch people, they believed asthma, chronic bronchitis, and emphysema are variations of the same basic disease, which is modulated by environment and genetic factors to produce these pathologically distinct entities. According to the British hypothesis, the content that asthma and COPD are fundamentally different diseases and asthma is viewed as largely as allergic phenomenon, whereas COPD results from smoking related inflammation and damage. Now, what are the risk factors for development of COPD? The risk factors include cigarette smoking, airway hyperresponsiveness and COPD, and the third is respiratory infections. There are many other risk factors as well that we are going to discuss, but let's discuss them one by one. So, number one, the risk factor is the cigarette smoking. There is accelerated decline of the FEV1 in the dose response relationship to integrity of the cigarette smoking. Airway responsiveness and COPD. Many patients with COPD also share this feature of airway hyperresponsiveness, increased airway responsiveness, and it is a significant predictor of subsequent decline in the pulmonary functions. Respiratory infections consist of, there are the various important causes for the exacerbation of COPD. Other factors, risk factors for COPD includes the occupational exposures, that is the exposure to the dust and fumes at work. Several specific occupational exposures that includes coal mining, gold mining, and cotton textile dust have been suggested as the risk factors for chronic outflow obstruction. Other risk factors includes ambient air pollutants, that is ambient air pollution is a much less important risk factors for COPD than cigarette smoking. Passive smoking exposure, that is exposure of children to maternal smoking, result in significantly reduced lung growth. There is also genetic consideration. With severe alpha-1 antitrypsin deficiency, that is proven genetic risk factors in COPD. So in the risk factors, we had cigarette smoking, airway responsiveness and COPD, respiratory infections, occupational exposure, ambient air pollution, passive smoking, and genetic consideration. Now the clinical presentation of COPD, how the patient of COPD will come to us. So whenever a patient of COPD is coming to us, there will be a history of cough and sputum production. So there will be cough, there will be production of sputum. Along with this, there will be exertional dyspnea with increased effort to breathe, heaviness, air hunger, or gasping. So there will be cough, there will be sputum production and exertional dyspnea with increased effort to breathe, heaviness, air hunger, and gasping. As the COPD advances, there is worsening dyspnea on exertion with increasing intrusion on the ability to perform vocation and evocation activities. So there is worsening of the dyspnea and exertion with increasing intrusions on the ability to perform vocational and avocational activities. In the most advanced stages, patients are breathless, doing simple activities of daily living. The physical findings in case of COPD, you will find in the early stage, patients usually have an entirely normal physical examination. The current smokers may have signs of active smoking that includes an odor of smoke or nicotine, staining of fingernails. In more severe diseases, the physical examination is notable for prolonged expiratory phase and may include expiratory wheezing. There are signs of hyperinflation that includes barrel chest and enlarged lung volumes with poor diaphragmatic exclusion as assessed by percussion. So there will be signs of hyperinflation of the lungs, and it includes barrel chest and enlarged lung volumes with poor diaphragmatic exclusions as assessed by the percussion. In severe airflow obstruction, it exhibits the use of accessory muscles of respiration. Sitting is the characteristic tripod position to facilitate the actions of the sternocleidomastoid, scalene, and intercostal muscles. The patient may develop cyanosis that is visible in the lips and nail beds. So there will be cyanosis that is visible in the lips and the nail beds. Now, what is tripod position? In the tripod position, the patient may sit upright with the arms supported on a fixed surface. This optimizes the function of pectoral muscles to expand the thoracic cavity. There is bluish red color of the skin that is known as polycythemia and cyanosis, and also hemoptysis. Emphysema. Now, what is emphysema? Emphysema is defined as the pathological increase in the size of the air spaces distal to the terminal bronchioles. So, what is there in emphysema? There is pathological increase in the size and air spaces that is distal to the terminal bronchioles with destruction of the alveolar walls. Now, there is destruction of alveolar walls that you are going to see in emphysema. And there is increase in the size of the air spaces distal to the terminal bronchioles. Etiology consists of alpha-1 antitrypsin deficiency, cigarette smoking, repeated respiratory infection, and occupational causes requiring forceful expiration. Prominent emphysema is termed as pink puffers. These are thin and non-cyanotic at rest and have predominant use of accessory muscles. Whereas patients with chronic bronchitis are more likely to be heavy and cyanotic, that are known as blue bloaters. Advanced diseases are accompanied by cachexia with signs of weight loss, bitemporal wasting, and diffuse loss of subcutaneous adipose tissue. In the pathology that is seen during the autopsy, there are various findings which includes lungs in the inflated position. So the lungs are in the inflated position. There is elastic tissue that is damaged. Diaphragm is depressed and the alveoli are overdistended with septa rupture and neighboring codes from the cyst. So what are the pathological signs that you are going to see in autopsy? The findings will include lungs in the inflated position, the elastic tissue that is damaged, diaphragm that is damaged, alveoli that is overdistended, and septa rupture and neighboring codes from the cyst. Now, pulmonary vascular bed is diminished, leading to the pulmonary hypertension. There is a reduction of the alveolar surface with the area leading to impairment of the gas exchange. So what is happening in emphysema? The pulmonary vascular bed is diminished and it is leading to pulmonary hypertension. There is a reduction of the alveolar surface area that leads to the impairment of gas exchange, and right ventricular hypertrophy or core pulmonale develops. Now the clinical features. The clinical features of emphysema includes dyspnea with grades. There is variety of grades of dyspnea that we are going to observe in case of emphysema. First is grade 0 with no breathlessness except with the strenuous exercise. In grade 1, there is breathlessness when hurry on the level or walking up the slight hill. Grade 2, when he walks slower than the contemporaries on the level ground because of the breathlessness and has to stop for breath when walking on the own pace. Grade 3, when the patient stops for breath after walking for about 100 meters or after a few minutes on the level ground. Grade 4, when there is too much breathlessness to leave the house or breathless when dressing or undressing. So these are the different grades. I may again repeat the grade. Dyspnea with the grades 0 when there is no breathlessness except with the stertorous strenuous exercise. Grade 1 when there is breathlessness when hurrying on the level or walking up a slight hill. Grade 2 when the patient has to walk slower than the contemporaries on the level ground because of the breathlessness, or he has to stop for breath when walking at the own pace. Grade 3, when he stops for breath after walking for about 100 meters or after a few minutes on the level ground. Grade 4, when there is too much breathless to leave the house or breathlessness when dressing or undressing. Now, what are the physical examination that you are going to see in case of emphysema? In case of emphysema, you are going to see the barrel-shaped chest of the patient. Barrel-shaped chest is the rounded, bulging chest that resembles the shape of a barrel. It is hyperresonant on percussion. If you are percussing it, there will be hyperresonance that you are going to observe. There will be obliteration of the cardiac and liver dullness. There will be diminished breath sounds with prolonged expiration and right ventricular hypertrophy. So there will be rounded bulging chest that resembles shape of the barrel. It will be hyperresonant on percussion and there is obliteration of the cardiac and liver dullness. There will be diminished breath sounds and prolonged expiration, and also there will be right ventricular hypertrophy. So I have shown the pictures in the presentation of the normal chest and also the barrel-shaped chest. Now, how to classify emphysema? Emphysema can be classified on the basis of distinctive pathological types as Centri-Asimar and Pan-Asimar. In the Centri-Asimar emphysema, it is the most frequently associated with cigarette smoking. It is characterized by large air spaces that are found initially in association with respiratory bronchioles. So you will find enlarged air spaces with respiratory bronchioles. It is most prominent in the upper lobes and superior segments of the lower lobes and often quite focal. The next variety is Pan-Asimar Emphysema. It refers to abnormally large air spaces evenly distributed within across the asimar units. It is observed in the patients with alpha-1 antitrypsin deficiency, and it has predilection for the lower lobes. There are some special forms of emphysema that you can observe. The first variety is compensatory emphysema. When the normal lung tissue undergoes hypertrophy to compensate for extensive damage. Next is the atrophic emphysema. In this condition, this results from the senile atrophy of the interalveolus receptor and the lung volume is not increased. The third variety is the bullous emphysema, where the air spaces exceeding 1 centimeter in diameter develops either genetically or acquired. With time, the bulla enlarges to become giant bullous emphysema. So this was all about emphysema, the COPD introduction and emphysema. In the next lecture, we are going to discuss about chronic bronchitis, the investigations of COPD and the management of COPD. So this was all for today. This session is powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.